Hello world, my name is Jacob Donn, and you are listening to Talk About It, a show that dives deep into substance abuse and addiction to uncover stories of hope and resilience. Today is August 19th, 2024, and we are going to talk about addiction. Addiction has affected and claimed the lives of countless people. But how does addiction manifest itself? And what steps can we take towards combating it? Today on Talk About It, I have the privilege of speaking with Joanna Champney, the Division Director for the Delaware Division of Substance Abuse and Mental Health, who will be answering our questions on all things addiction. How are you doing, Joanna?
Hi, thanks for having me, Jacob. I'm so happy to be here. I'm doing well. How are you?
I'm doing great.
Good.
Let's kick off this interview by examining your journey in prevention. So for our viewers at home, could you tell us a little bit about your story in prevention and addiction from the beginning until now?
Sure. Well, I've been working in Delaware my whole career. I consider myself a through and through Delawarean. I had the pleasure of working in the nonprofit sector for many years, where we were serving people at the Delaware Center for Justice who were justice involved. So that included victims of crime, youth who were navigating the justice system because of some kind of issue that had occurred at school, people who were leaving the prison system and trying to get their feet back on the ground, navigating employment and addiction treatment, mental health issues, probation and parole, and a number of other programs, including policy reform. So we were looking at issues around bail reform and justice reinvestment. And so as a part of that work, which I absolutely loved because it combined a focus on service delivery for people who are justice involved with advocacy and policy work. That really gave me tremendous insight into one of the main drivers of people going to prison in the first place, and some of the main drivers of what made it challenging for them to come home after prison and integrate successfully back into the community. And those issues included substance abuse and mental health. And so that really was a place where I got to see firsthand through the eyes of our clients the issues that were preventing them from being successful, and the issues, sadly, that followed them into the prison setting where, sometimes they were struggling to get the substance abuse and mental health services that they needed. And so when I left the nonprofit sector, heading the Delaware Center for Justice, where I was the executive director, I had the honor of joining the Department of Correction, a Delaware state agency, where I was the chief of planning and research. While I was there, then Commissioner Claire DeMatteis was able to secure resources for us to add a prisoner reentry effort at DOC in my unit. And so we were able to more than double the size of my team to include a new and refreshed emphasis on prisoner reentry. And we were really lucky to get those resources, which enabled us to really drill down and figure out what is preventing people from leaving prison and integrating back into the community successfully. So part of what we were looking at during that time was the programming that was available in the prison to help people get ready to go home. So what kind of addiction treatment programs were there? What kind of mental health services? What was the quality of the programs that were offered in the prisons? And so I had a really amazing opportunity to work with my colleagues there on a number of initiatives to improve the quality and delivery of those behavioral health programs. And then similarly, I had the privilege of working with probation and parole and other community-based entities to help improve the experience for people who were leaving prison and coming home. So one of the things that we started working on was something called the Transition Accountability Plan that would be used from the time someone was incarcerated, and that plan would follow them all the way through to probation and parole post-release, so that the individual is working with them, whether it's a correctional counselor in the prison or a probation and parole officer, and later, hopefully, reentry support staff, maybe at nonprofit agencies, would be able to utilize that transition accountability plan to track what the individual's needs were based on an assessment. And then the programs and resources the person had accessed successfully to address those issues and what was still needed to help them be successful. So I really enjoyed being a part of that very systematic approach. We were leveraging a lot of federal resources at the time to show us what had been successful in other states. We participated in a program called NCJRP, the National Criminal Justice Reform Project, and that allowed us to look at what had been successful in other states and focusing on high quality evidence-based programs in the prisons, which we were focused on in Delaware as well, and then focusing on good transition planning and good warm handoffs between all those stopping points as someone is flowing down from prison to community. Those were some of the focus areas. So I really got my feet wet at that time and working around the behavioral health programs that were so integral in helping people get ready to go back home. And then I had the honor of being selected to lead the Division of Substance Abuse and Mental Health, where I am now. And so now I'm continuing to work in that space, but now really solely squarely in the behavioral health space. So one of the things I really enjoy about my position is the ability to continue supporting the needs of the Delaware prison system. So due to a variety of boards and commissions and things that I serve on, I can continue to help them identify resources and tools, and our state opioid response funding. Some of that we're able to funnel through to the Department of Corrections so that they can improve the delivery of behavioral health services for people who are still incarcerated. So it's nice in Delaware because we're a small state that often you get to kind of move around between sectors, and you learn and grow as you do that, and you can bring that experience to bear to your next position, which I feel really lucky that I was able to do, moving from Department of Correction over to the Division of Substance Abuse and Mental Health.
You covered quite a bit of ground on corrections and on the Addiction Action Committee and on addiction in general, and I'll definitely get into that a little later. I want to tackle this topic of addiction head on, though. There is quite a bit of evidence from reputable medical sources that, and just anecdotally, obviously addiction does not happen overnight. It tends to manifest itself over a period of time. And many sources say that there are different stages of addiction. Could you elaborate on these different stages of addiction and, in general, how someone with an addiction or substance use disorder, how that may progress in their life?
Sure. Yeah, it's a great point. One of the things that we talk about a lot at DSAM is just how widespread the opioid epidemic is. Researchers now estimate that about 3 in 10 adults in America know someone who's affected by the opioid epidemic. I actually think it's much higher because I hardly have any conversations where the person I'm speaking with or dealing with doesn't personally know someone. So I think it's probably a lot higher than 3 in 10 adults knowing somebody who's opioid affected. But sadly, of that group, more than half know someone who actually has died from addiction. And so it really goes to show there's really hardly any family in the state and in the country that hasn't been affected in some way, shape, or form by addiction and by opioids in particular. So, I think it's important to pause on just realizing the human impact of this epidemic. And so, when we think about addiction, it's so important when someone is, dealing with their own addiction to talk to a clinician who can help them assess kind of where they're at in terms of their addiction. One of the things that our state offers is bridge clinics in each of the 3 counties where people can walk in. The one in Newcastle County has later hours. The ones in Kent and Sussex County run during normal business hours. But people can walk in and request to talk to a clinician to get an assessment and talk to somebody about how severe their addiction is, what are the symptoms they're experiencing. We call that assessment the ASAM criteria, right? So a clinician who's well trained in how to assess that will ask a bunch of questions. How is it impacting your life? Is it, what are your symptoms? How long have you been using? What types of substances? How does it impact your mental health? Things like that. So they will map out in all these domains the information that's shared. And then together with the patient, they'll help them to navigate what type of treatment level the person needs. So for example, someone might need withdrawal management, which is the highest level of care that we offer. Or maybe if they're already in treatment, they could go to a sober living house if that's something that they need, right? And then there's all sorts of resources in between. That includes things like intensive outpatient treatment, residential treatment, regular outpatient treatment. So it really is highly customized. So, one of the things that I really like to emphasize is it's truly important to talk to a clinician who is trained, who can listen to the symptoms and ways that addiction is presenting in someone's life and can give some clinically based recommendations for the level of care that's needed. And then, the other crucial thing is that insurance is often perceived as this major block to people being able to get care. So if the person's unemployed or maybe they've maxed out their insurance benefits, there's often a fear that they're not going to be able to get the help that they need. So the state has pumped a lot of resources into a robust system of care so that people without insurance and those who are underinsured can get help. And then one of the other things you talked about was like things that lead into addiction. So it's really interesting. In Delaware, our colleagues at the Division of Public Health were looking at the employment information for people who had overdosed. And one of the findings that they had was that two very prominently represented employment industries were restaurants and construction. So they decided to build some toolkits that could help the state target employees and employers in the restaurant industry and in the construction industry. When you think about the construction industry, a lot of people who end up taking painkillers were injured on the job, right? The construction industry is a place that's rife for opportunity to be prescribed opioids for pain management. And so I think those two industries are at pretty high risk. I think with restaurants, they employ a population that may be transient. They may be sort of between jobs or getting back on their feet, working nights. So there may be some risk factors to working in restaurants that make them more susceptible. And so providing toolkits to those industries to help them understand how do you spot behavior, right, that might indicate someone has a drug problem. What do you do to reduce somebody's risk? How do you respond to an overdose, including how do you use Narcan to reverse an overdose? And how can you have people on your employment team who know enough about these types of issues that they can guide somebody who's struggling? They can spot somebody who's struggling and offer help, or they can respond if somebody's unconscious because of an overdose. So, really developing some very targeted strategies for industries where we know addiction may be more of a risk factor, I thought was such a great idea. And we were so fortunate recently to have those programs actually transition over to my division. So shout out to my colleagues at Public Health who developed the program. And we're really happy to keep both of those projects going now.
I want to talk now about the Addiction Action Committee, which you serve as one of the co-chairs of. Obviously, the Addiction Action Committee deals with all things addiction, but specifically the mission statement that I found from one of the PowerPoint presentations that's publicly available online. The mission of the Addiction Action Committee is to, quote, develop and monitor a coordinated and comprehensive approach when it comes to dealing with addiction. So could you tell us what exactly is that approach that the Addiction Action Committee and the state of Delaware in general is taking towards addiction?
Sure. I'd be happy to talk about the Addiction Action Council, the AAC. We recently reinvigorated the AAC. We have a bunch of new members who are now joining us, and I have the pleasure of co-chairing the AAC with Dr. Rebecca Walker from the Division of Public Health. And that group is really tackling some very exciting and I believe very poignant issues right now. So what's great about the Addiction Action Committee as opposed to the overdose system of care, which focuses on sort of the hospital system's response and emergency medical system response at the point of overdose and beyond from a healthcare perspective, the Addiction Action Committee kind of focuses on everything else, right? Like what resources do we have in the community to respond to addiction? It includes aspects like prevention, and it also includes youth and adults. So we have a lot of opportunities to make a difference. And we've attracted a list of some really great members who have joined our subcommittees. And so I'll name a couple of the projects that we have going right now that I think are particularly exciting. One of those is helping providers figure out how they can integrate wound care into their addiction treatment environment. So why would wound care be important in addiction, right? So you might be thinking that doesn't sound like something you would need to provide in an addiction treatment space. Well, interestingly, I don't know if you've heard of the substance xylazine that's appearing in a lot of street drugs these days. It's super, super common. And unfortunately, it causes really serious skin lesions on people. It's not just at the site of injection, but often it's also at the site of injection. And it's actually a veterinary tranquilizer, definitely not approved for human use, very dangerous, and it causes these necrotic skin lesions. So someone who's been using for a little while is very prone to having these open sores on their body. You can imagine the medical expertise that's needed to deal with something like that, especially if the wound gets really large or infected. And so that's one of the things we've discovered in the last, 3-4 years or so, as this has developed more and more, that providers who maybe previously were focused just on the addiction treatment now also have to consider, we don't want to lose patients, right, who are having these issues with wounds. So how do we make sure that those providers know what to do? And number two, that they know how to get reimbursed for those services, because those professionals have to be able to reimburse for that service. So that's just one example of something the AAC, my colleague Kate Brookins and her colleagues from the Division of Medicaid have been looking at that. What are some of the billing codes that these providers can utilize so that they can bill for wound care as well? So what might sound like a little administrative issue actually is helping the system as a whole be able to meet the needs of real people who need addiction treatment services, so that the doctors there can properly bill for those services, and then they can advertise that they can provide that level of care, right? So again, I think it gives patients the confidence that they can go to that provider and that provider will be able to meet their needs. Another exciting piece of work that we've been looking at recently is preparing for the influx of legally available retail marijuana. So we know that already medical marijuana is legalized. Marijuana has been decriminalized, and very soon you've probably been seeing in the news that, that the application process just opened up for cannabis retailers who want to sell it to the public. That's opened up. So in a very short amount of time, people in the community will be able to purchase it. And so we know that just as alcohol availability at liquor stores, there are some risks with underage drinking, underage consumption. Similarly, with the expanded access to retail cannabis, we know that as a state, we need to get ready to respond to a potential uptick in juvenile use of cannabis. So the Addiction Action Committee has been looking at what is the research around youth use of cannabis? What are some successful messaging campaigns that other states have used to really get the word out to young people about the impact that cannabis use can have on their developing brain, on their motivation levels, and some of the other health impacts. So, again, like AAC gives us an environment to look at very timely issues like wound care, like retail availability of cannabis. And then one other item that I'll mention is harm reduction. We've been looking at how in the state we can lower the barriers to people being able to get access to alternatives. And one example that I'm really proud of is the harm reduction vending machines we're going to be rolling out. So those will be available in 5 locations statewide. People will be able to access them 24/7, completely free, completely anonymous. They don't have to talk to a live human. They can walk up to the vending machine, type in their zip code, and they'll be able to access Narcan at no cost, safe sex kits, pregnancy tests, all sorts of resources that they might need. So those are just a few examples of things that the AAC is working on.
Yeah, it's great to hear all of the wonderful projects that the AAC is contributing to. But now I want to switch gears and focus on corrections. You have quite a bit of extensive experience in corrections, as well as with addiction and drug-related issues for incarcerated persons. And I'm curious, when it comes to prisoners and when it comes to corrections in general, do prisoners have any specific needs or priorities when it comes to addiction or treatment that are different from the general public?
Well, that's a great question. I would say their needs are not necessarily different, but there's 2 important points to make here. And one is that behavioral health issues are seen at a higher rate in correctional settings. And secondly, it's very challenging to deliver good quality addiction treatment and mental health treatment in prisons. Imagine that prisons are a little city, right? And all the challenges, and everything is very tightly scheduled. Meals are tightly scheduled. The education schedule is very tight. The movement is very controlled, which is different than in a community setting where people can come and go. They can come and go to their treatment appointments at different times. So, the setting itself of prisons, for people who've never worked in corrections, I think they may assume that it's a lot more free-flowing. But all of Delaware's prisons are maximum security prisons. We don't have facilities, at least not at the level 5 level, like you've seen on TV where people are sort of milling about. Our community correction centers at level 4 are a little bit more like that. But we don't have a jail system in Delaware. All of our jails and prisons are actually combined, and that's what we call our level 5 facilities. So one of the biggest challenges is really the mechanics and the logistics of providing addiction treatment services that are specialized. And that specialization is one of the things that my colleagues and I at the DOC had an opportunity to work on. So what do I mean by specialization? So in the community, when we began the interview, I was telling you about how a clinician would assess what ASAM level of care someone needed. So we don't just pick out of the air, oh, sounds like you need detox. And so similarly, in a prison environment, ideally, you would want to customize that person's course of addiction treatment, right? But those logistics that I mentioned, what housing unit they're in, the daily schedule of the prisons, all of these factors can really pose a challenge to a limited number of behavioral health staff, and then several hundred to thousands of inmates in a facility. So delivering customized addiction treatment really was a challenge. And so one of the things that we did, and my colleagues have really done a great job with this project at DOC, was to conceptualize the Road to Recovery, or R2R program, where we did different tracks for different levels of addiction severity. So, we were able to customize the dosage that people received in terms of hours of addiction treatment. And so I think by creating 3 different tracks where there was different content, it wasn't just one size fits all, right? So is it as customized as you would get out in the community? Maybe not, but 3 tracks certainly was better than the one size fits all, where it was either addiction treatment or no addiction treatment. And so, I think that people are able to have their needs met in a more customized, specific way. The content is tailored. The amount of time that they spend in treatment is tailored. So I think that really represents a major evolution that Delaware DOC should be really proud of.
The last position of yours that I want to talk about is your work as the division director of the Delaware Division of Substance Abuse and Mental Health. Obviously, it deals with substance abuse and addiction, but I'm curious personally, with your work as director and looking at your a few years that you've been at the division, could you tell us a little bit about your personal work and what you do as director of the Delaware Division of Substance Abuse and Mental Health?
Sure. Well, a day in the life. It might include everything from, dealing with landscape issues in our administration courtyard to, meeting with you to do an interview about what our priorities are and what some of the work is that's happening in the state, to participating in planning to help figure out how do we want to prioritize our grant dollars, to helping a constituent navigate some kind of access to treatment issue, to, preparing for the upcoming shift in the governor's administration. So every day has so many different aspects. And that's honestly one of the things that I really, truly love about my job, is that every day is different. Every day is filled with a ton of variety. One of the things that I feel really passionate about is integrating data into making plans to help the state meet the needs of its people. When I arrived at DSAM 3 years ago, I discovered that we had this treasure trove of data and information about people who were receiving addiction treatment. And also we had access to this really cool tool called OD Map that maps where non-fatal and fatal overdoses are happening. And that information was sort of being reported retrospectively at the end of each quarter. But I really felt like we could be doing more to use that data to take action. Let's use it to inform what our next step is going to be. So it took us a couple years, but we've gotten the Overdose Response Center up and running. And we're now utilizing that OD Map data, which is populated by police data and paramedics data, all sorts of inputs, and maps it out. We take that information and say, okay, where were we seeing hotspots over the weekend? And where do we need to send response teams out to distribute Narcan, to talk to people about treatment options? So that's one of the things I'm really proud of. And so although the days are busy and very varied with all sorts of different demands, our leadership team really tries to take the time to look at where the data is pointing us instead of operating on autopilot. I think we need to be constantly evolving as a state, using the data that we have to look at where the needs are in the state geographically down to the neighborhood level and what the needs are. And so I think starting the ORC is one example of something I'm really proud of, and one thing that I think will really make a difference, and hopefully saving a lot of lives.
Joanna, you've given us so much great information and knowledge on addiction, on treatment, and about your personal career. I want to ask one final question for this interview. We've spoken a lot about addiction, and we've also looked at how addiction has impacted and claimed the lives of so many people. Of course, the general public, we talked about corrections and with incarcerated persons. So I want to know, in your personal opinion, what needs to be done to curb addiction and bring about an addiction-free, healthier world?
As I look at the data in Delaware and I talk to consumers and I talk to treatment providers, one of the things that comes up again and again is that we have beds available, we have spots available for treatment. And there seems to be a real barrier between people being identified as having an addiction issue and actually getting to treatment. And staying in treatment is also an issue, but I think working on issues around stigma, addressing the barriers that people face to even getting through the door in the first place, to step forward and say, I need help and I'm going to go to an addiction treatment facility to get help. There's more that needs to be done. When we look at just how vast the need is of people who have an addiction issue, I was looking at the numbers today, and we believe that there's probably about 13,000 to 14,000 uninsured Delawareans who have an addiction issue. So then why is it that we have vacancies at some of our treatment facilities? Wouldn't you assume that those facilities would just be overflowing with wait lists? Sadly, we don't have wait lists at any of our levels of care. So that's really one area I think we need to dig deeper on. What is keeping people from accessing the services that we're funding? And I think, there are some things that we need to look at, like quality of treatment, making sure that transportation and childcare, some of the things that keep people from being able to not worry about their life for 60 days to go access treatment. We need to deal with some of those things. Simply having the beds, having the spots isn't enough. Now we need to figure out what's keeping people, and we know some of that. We know there's been a ton of research around social determinants of health. So we know what the barriers are. Now's the time to buckle down and do more to help people focus on getting better.
I see. Absolutely. Joanna, thank you so much for all the wisdom and insight you provided today. For our viewers at home, that was Joanna Champney. She's the Division Director of the Delaware Division of Substance Abuse and Mental Health. My name is Jacob Donn, and we'll see you next time on Talk About It.